Good afternoon and welcome to our COVID-19 planning update for April 6, 2020. My name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. I'm pleased to be joining you today with three of my colleagues to talk a bit about the state of our capacity planning as we respond to the COVID-19 pandemic. This topic has been undergoing a lot of discussion at the command center and across the organization as we prepare to ready ourselves for the increasing numbers of patients that we know we can expect in the weeks ahead. So at this time, let me introduce who's with me on this webinar. I have our President and CEO, Rob McIsaac. I have our EVP, Clinical Operations and Chief Operating Officer, Dr. Wes Stephen, and as well our VP of Community Medicine and Population Health, Sharon Pearson. Welcome all. So Rob, let me start with you. Can you give us an update about our capacity planning? What's the discussion currently in broad strokes? What's critical and what's happening?
Yeah, sure. Thanks, Aaron, and thanks everybody for joining the call. Well, we're doing all that we can to plan for what may be headed our way. I think we're bringing to our planning the notion that we'd rather be over-prepared than under-prepared. But we're trying not to engage in any hubris. We know that it's a very challenging situation headed our way, but we're doing all that we can to prepare for it. We have been continuously planning based on scenarios that look at our local demographics, together with what's happened in countries literally around the world to try to better understand the likelihoods that we'll be facing as the virus begins to take deeper hold within our community. The large part of our preparedness depends on our ability to redeploy staff to the parts of our enterprise that needs them the most. In that respect, we're really relying on the flexibility and availability of our workforce, especially frontline providers, to take on new and different work in the areas where we need workers the most. So far, I'd have to say that everyone has stepped up to the plate in ways that we would have previously thought unimaginable. So your continued dedication and commitment is appreciated beyond words. So thank you, everybody. Tomorrow, we'll be joining with our partners at Public Health and St. Joseph's Healthcare and sharing our capacity planning work with the media. We wanted to share them with you first, and so I'm encouraging you to listen to the duration of this webinar to understand how we'll act as this situation escalates in our community. We're planning to a model and associated targets assigned to us by the Ontario West Regional Planning Group of Ontario Health. Using these models and these targets, HHS has identified a staged approach that's based on expected volumes of COVID patients requiring care locally here within the city as the pandemic progresses. We've staged our approach with each stage bringing additional capacity online. The activation or trigger to each stage will occur when we hit 50% of the projected COVID volume within the current stage. So we'll continue to step up our efforts and our capacity as this situation unfolds. Dr. Wes Stephen and Sharon Pearson are going to comment in more detail about the projections we're anticipating and how we might respond to them. Before they do, I just wanted to comment on the work behind this planning. This assessment has been incredibly challenging and time constrained, and the teams involved are really to be commended for what they've been able to pull together within a relatively short period of time. We've made incredible strides in creating immediate capacity while at the same time executing on early work to decant the hospitals and design alternative patient care capacity, both inside and outside of Hamilton Health Sciences facilities. Again, this is work none of us would have thought even possible 3 months ago, and yet these teams have been able to pull this together. It's been an enormous amount of work, and my deep thanks go to all of those who've been involved in doing this work. With that, Aaron, I'm going to pass it back to you.
Thanks a lot, Rob. Dr. West Stephen, I want to go to you first, and Rob just walked us through some of the, this volume of work that we've managed to accomplish in a very short amount of time that would be unprecedented in so many scenarios. Can you talk a little bit about that? What's that process look like? Who's been involved, and over what time period, and what's happening there?
Thanks, Aaron. So, as we all are aware, we've had significant planning occurring at Hamilton Health Sciences. The team of capacity has been led by Cheryl Williams and Dr. Khalid Azam. They've brought together a very dynamic team of members that represent the whole organization, including clinical operations, physicians, decision support, planning and analysis, HR, just to name a few. They have been very active in working the scenario planning up, as well as looking at the ability to meet that from a capacity point of view. This group has based the plan on some guiding principles that I think are important to articulate. First and foremost, we believe that it's important to cohort COVID positive patients into units and into sites as much as possible. So there is sites that we will attempt to maintain as COVID negative. As example, our St. Peter's site, which is a high-risk patient population if they were to get COVID positive, if they did get the disease. As well, there is priorities around for the organization to focus on, and it is about building capacity in our intensive care units and our acute medical wards. As we know, those are going to be two areas of pressure for the organization. There has been work around freeing up clinical space, and this has meant scaling down of scheduled care and to relocating some of our patients to other areas across our enterprise, and as well as working towards decanting into the community and other areas within outside the walls of Hamilton Health Sciences. To say that this is, to emphasize, this has been a regional approach with our partners with St. Joseph's, as well as our community partners as well.
And I guess as we, as Rob had mentioned, we've been looking ahead and projecting. It's a fluid situation. No one can say with absolute certainty how many beds we need. But if you could think about those targets, like what exactly are we trying to accomplish by the end of this month? What does that look like?
So there have been various agencies, including ourselves, that have been doing modeling over the demand and what that we think the capacity is going to be required. These projections lead us to thinking about not just the physical space of where we would put patients, but also the medical model, the staffing model, the equipment that's required, and all other resources to support the needs of our patients. Ontario West has given us a target for the end of the month of April that for the number of COVID patients that they're expecting that Hamilton Health Sciences will be looking after would be 178 acute beds and 60 critical care beds. This is above and beyond what we need to maintain for essential services in non-COVID patients. As you've alluded to, Aaron, this is extremely a very fluid and evolving situation. These are projections only, and we have done some internal modeling that would suggest that in the worst case scenario, over the duration of the pandemic, that we may need to increase our capacity to up to 1,000 beds for COVID patients, including of those 1,000, that 400 would be critical care. I'm happy to say from the efforts of the collective organization of our teams, we have already freed up 300 bed capacity as initial stage for this work.
And that's an immense accomplishment for us. But hearing the number 1,000 moving forward, or as many as 1,000, like when we get to that peak, what will our planning phases look like? Rob mentioned taking a waved approach to escalating capacity. Can you talk a bit about that as we get closer to the peak locally? What will we be doing and thinking about to try and create that space?
So there are, in our thinking, 5 ways of escalation. The first one, which we're currently in, is ramping down non-essential services and scheduled procedures. From that, we also are actively, and Sharon Pearson will speak to this, is about decanting patients within our enterprise and outside of our enterprise to create capacity. The third phase is to open net new bedded capacity in our hospital in conventional spaces. This would include a doubling of patients in critical care and looking for spaces that have been designed to look after patients. The next phase is phase 4, is really opening new bedded capacity in our hospital in very unconventional spaces. And that includes some areas in our intensive care units and on our wards, and potentially looking at our auditoriums. And the 5th phase is really opening new bedded capacity outside of our hospital. And we are, just to be clear, in conversations with local hotels, looking at opportunities to place patients, appropriate patients, in a hotel setting.
Thanks, Wes. Sharon Pearson, I want to ask you a question now. You've been deeply involved in this work as it relates to the decanting efforts in our hospital, and also this projection forward to think about the capacity we're going to need as the pandemic starts to increase in our community. What does it look like as we head out of wave 1 and we start to move into wave 2? Can you talk a bit about what will happen next?
So the work in wave 2, we've been focusing in 2 streams of activity. One is looking at how can we avoid any unnecessary hospital visits or admissions. And the other is by ensuring that patients who no longer require less interventional or medical care are transitioned to spaces outside of the hospital. And some of those will be conventional and some of those will be unconventional. So if we think about our strategies to avoid unnecessary visits and admissions to hospital today, we are launching a new 24/7 line for the physicians and staff in our long-term care homes, all of the long-term care homes in Hamilton, so that they can access a physician and then they will be triaged depending on what their need is, and we will support the clinical teams in the long-term care homes to care for the patients and hopefully avoid those unnecessary visits to hospital. We know some patients will still need to come, but we will do our best to support the team. So a nice partnership launching today with a number of community agencies and also our CFER group, which is the Paramedic Research and Education physician team. The other stream of work relates to relocating patients or transitioning patients. And the 3 populations that we've been focused on for this transitioning work are the ALC group, the rehab group, and the complex care group. And in order to do that, we've been working in partnership with St. Joe's and a group of community partners looking at expanding our transitional care bed model in the community. And so looking for bedded capacity in different retirement homes and supported housing agencies that can accommodate the patients with the needs that we have. So we do have some beds that are available. Some of those beds need some physical improvements. And we are looking for some staff within our community agencies and partners to support the care that's required in those settings. We are also looking at how we can use our sites most effectively between regional rehab and our St. Peter's group. So we will look at the patients within the St. Peter's group as opportunity to move to some of those conventional spaces outside of our hospital, as well as some of the unconventional spaces. With respect to wave 5, and Wes may have alluded to this, so in addition to looking at the admission avoidance and the transition of patients to conventional settings, we're also working in partnership with St. Joe's to develop an unconventional environment. And we've seen these in other countries. We've seen them in Canada, and now we see them in Ontario. And typically they're tents, or they could be arenas, or they could be hotels. And in our discussions determining what is best for us and for HHS and for our patients, the preference is looking at those that have the critical infrastructure that we need, such as laundry and food services, and also options for patients that can include rooms or large congregate spaces as well. We have spoken to many of the hotels and convention facilities in the broader Hamilton region. We're not quite ready to announce our definitive plans yet, but I can say we're very close and we're very confident that we're moving in the right direction with those plans.
It's an incredible amount of work and an incredible amount of preparedness on the part of all of those involved. And as acknowledged, it's a fluid situation, but Dr. West, Stephen, I have to ask, once we've exceeded the capacity in our conventional spaces, particularly in that sort of wave 3 area, what does that look like internally for our hospital?
So wave 3 is really looking at doubling up patients in many of our rooms. As an example, our plan in the intensive care unit in many of the areas is to actually put 2 patients in 1 room. The teams have looked at this, believe that it could be physically able to do this, and is a staffing model that is less than ideal, but is doable. As well as we would be looking in the next wave, which is more of the unconventional spaces, and these are such as our auditoriums or our sunrooms. I must admit the challenge is resourcing from a staffing point of view and equipment point of view, and there's active work looking at wave 4, and the planning continues.
So I think we'll close it there, recognizing that there is still much to happen in the days and weeks ahead. Our commitment as this fluid situation evolves is to continue to update the organization, to continue to hold these webinars, to be able to explain decisions as they're made, and to bring forward the latest information as the pandemic progresses. I want to thank our webinar participants today for being a part of this discussion. This will be posted on the hub for those of you that want to share it. Please do so. Please continue to send questions to the staff email line regarding our COVID-19 response so that we can inform the content of future webinars. Until our next dispatch, to all of you, thank you and stay safe.